Good evening, everyone. Today we can discuss on how to manage a stage 3 non-small cell lung cancer and what is the role of immunotherapy in the current era as a consolidation treatment post chemoradiotherapy in a stage 3 lung cancer. Well, if we just look into the epidemiology of lung cancer, is one of the most common cancers which we have, and the big problem with lung cancer is it's one of the vital organs and has high translation to mortality. A majority are they present in advanced lung cancer, and inevitably it converts to mortality. And we have some one-third patients who present with a locally advanced disease, but they're not amenable for surgery. And then we have another less than around 20% patients where we may think of surgery or look at the eligibility for surgery. So it's a difficult disease to treat because it has a high propensity for metastasis. We pick it up in an advanced stage, and surgery is not an easy job as far as lung is concerned. So that's the reason why lung cancer is a complex disease, and so much we speak about. Well, if you look into uh, the staging of lung cancer, uh, we have the TNM staging. The most important here is when the tumor, when the lung, where the primary tumor starts invading the neighboring structures. It is in close proximity to neighboring structures, especially the great vessels, the pericardium, heart, bronchus, trachea, esophagus, vertebral body, and recurrent laryngeal nerve. So all these invasion of uh, uh, vital structures make this lung cancer an inoperable disease when these sort of things happen, and also has a high propensity for lymph node metastasis. So we have hilar lymph nodes, we have ipsilateral mediastinal, we have contralateral mediastinal, and then we have supraclavicular lymph nodes. So inevitably, as the T size increases, the propensity for mediastinal spread also increases. Not to stress more on, if you, it's not like a head and neck cancer or a uterine cancer, uh, where even if lymph nodes are involved, we can dissect out the lymph nodes, which converts to an improved survival. It's not like an abdominal malignancy. The problem with this is the moment the lymph node involvement is quite extensive, where it becomes N2 or N3. Uh, the moment the stage advances, it becomes stage 3B or stage 3C. On that occasion, even if a radical surgery is done, it won't translate to survival. So surgery is confined to something around stage 3A at the earliest, or a single station N2 disease at the max. So radical surgery is helpful, and they qualify for only a select set of patients, and we cannot offer radical surgery for majority of patients. So however, we have this significant number of around two-thirds of patients who present with a locally advanced disease, where uh, we need to consider chemoradiation as the way, as the main way of treatment. So this is how we classify as N disease, where we have ipsilateral hilar N2 as the ipsilateral mediastinal pretracheal, and then the N3 where it is contralateral mediastinal or supraclavicular lymph nodes. So if we have an early stage disease where we have an N1 disease and an operable primary, we should assess them for radical surgery. The moment it is N2, and if it is single station N2 and the primary is resectable, then we can still go ahead with radical surgery. The moment it becomes N2, multi-station, then the chances that surgery offers a long-term cure is quite remote. So these patients we need to consider for uh, radical chemoradiotherapy. Uh, so again, if you look into an N2 disease, we cannot generalize that all N2s will go for surgery or all N2s will go for chemoradiotherapy. It is again an MDT where we need to discuss the amount of resectability, and then proceed ahead. So it is basically case-to-case decision where we need to make as far as N2 is concerned. So N1, we are pretty sure if the primary is operable, we need to offer surgery if the patient is fit, whereas N3, no surgery at all. We must offer chemoradiotherapy as the treatment option if feasible. The moment it is N2 disease, then we would like to explore the option of surgery. If it is a single station disease and non-bulky node, then we would like to explore option of a definitive surgery, or maybe a new adjuvant chemotherapy followed by a surgery. Well, if it is a multi-station N2 where getting a R0 resection of the lymph nodes is quite difficult, then it is futile to go ahead with surgery. Instead, we cannot go ahead with radical chemoradiotherapy. So this is what points we have as far as uh, uh, lung cancer surgery is concerned. So before we embark on to the radical surgery for lung, as far as lung cancer is concerned, mediastinal staging becomes extremely important. So we do mediastinal staging with IBUS, and we also do mediastinal staging with a mediastinoscopy. So we do it a stage procedure. Like I do a mediastinoscopy, look for what are the levels of lymph node involvement. We do a frozen, and at the same sitting, we can convert that to a lobectomy or a pneumonectomy, whatever at that particular point. So, well, if Dr. Devmulli is there, he can share his experience as far as how does he look into the what how to label, how to look into the specimens, and how do you decide on frozen section, and what are the chances that the lymph node becomes positive on after post surgery. So what is the upgrade? What is the upstaging post surgery? Dr.
Yeah,
Devmulli, you are there?
yeah. Thank you, Dr.
Yeah, yeah.
Chandrakanth.
Hi, hi.
Basically, you see, the thing is that in mediastinoscopy, the surgeons used to send us the lymph node, and in the grossing room, the first choice is that to dissect as many as nodes are possible. So, and one of the good thing is that most of the cases, the mediastinal nodes, they have the black pigments. That's why they are sometimes easy to localize, easy to visualize, basically. And there are different grossing techniques to take the frozens depending on the different institution. In TMH, basically, we submit the entire node, we dissect it in multiple sections and submit the single chunk. And the most of the high volume institutions, they showed that the positive predictive value is 100%, and the sensitivity is not so high. It is 94%, almost 94-95%, but the specificity is 100%. So that means the which is positive, that is definitely positive. But in high volume centers also, they have shown that some nodes you can be missed, but I don't think that will create a problems in the decision makings. If the nodes are positive, if the pathologist give a report positive, that is definitely positive. So the positive predictive value of the nodal assessment in frozen section of the mediastinal nodes are almost 100%, depending on the different institutional experience.
Okay, okay. So, so is there anything post surgery you do a lobectomy or a lymph node dissection? Is there anything specifically you look into as far as a post-op histopathology is concerned?
See, if the surgical is possible, then basically in the grossings we used to give the parenchymal cut margins. The report should contain the parenchymal cut margins, the bronchovascular cut margins, and if it is squamous cancer, the report should contain the any in situ carcinoma component is there or not, the status of visceral pleura, the parietal pleura, the chest wall is involved or not, and the surrounding the residual lungs appearance. Is there any smoke inhalator changes, any atelectasis changes are there or not? So that parameter, and definitely the what is the tumor type, and it is involving the any there any lymphatic emboli is there or not? It's involving the any large cartilage, or it's a bronchial cartilage involvement is present or not? That's these all parameters should be there in a report.
Okay, okay, okay. Well, Dr. Pradeep is there. Dr. Pradeep. Okay. Uh, so, well, if we proceed, so mediastinal lymph node staging is an important part of staging as far as a locally advanced CA lung is concerned. And so, as I was discussing, the surgical candidates are not many. We want a N1 disease or a single station N2 disease. Even if it is a single station N2, we would like to give neoadjuvant chemotherapy and then consider surgery. If it's a multi-station N2, then we should consider CTRT. Uh, Dr. Monidipa, so how do you select your patient population for whether it is a radical surgery or a CTRT as far as the nodal staging is concerned? Dr. Monidipa has joined.
I think Monadipa is not there. See,
Okay, so one sir is there. Chalo, okay. So, so this is how we decide on uh, surgery versus radical chemoradiotherapy. Manivrata, it's not moving. Can you help me out? Yeah. So well, so in the present day, we have multiple radiation modalities, right from conventional radiotherapy to 3D CRT to IMRT to IGRT, and even we're speaking of adaptive radiotherapy and also proton uh, therapy as well. So the whole intention is because the vital organs like heart, great vessels are in close proximity to spare these organs from radiotherapy. So we need to have these novel modalities of radiotherapy. So the efficacy almost remains the same, but the non-cancer mortality because of injuring vital organs is the one that plays over here. So in the present day, we usually don't give a blanket adjuvant radiotherapy for all patients post surgery. So we can consider adjuvant radiotherapy post surgery in patients where there is margin positivity or there are multiple N2 disease, multi-level N2 disease which is involved. So in these and if the mediastinal lymph node dissection is inadequate, so in all these conditions where we can consider post-operative radiotherapy, however, there was a meta-analysis that showed that if we give blanket radiotherapy even for early stage disease where the mediastinal lymph node involvement is not that extensive, by using conventional techniques, there we had a worsened outcome. But however, whatever nuances we had with that trial, so if we can give a proper technical radiotherapy with a proper patient selection, adding post-operative adjuvant radiotherapy has added to survival. Uh, there has always been a discussion as far as escalating the doses of radiotherapy if I cannot deliver adequate doses of chemotherapy is concerned. So, so do we have any radiation oncologist who can add something on this?
Hello?
Harmonidipa,
Hello,
I
can
can
you
hear
hear
you.
me?
Yeah. Please tell.
Yes, my voice is not stable. So, yes, so there are like trials seen if only radiation is modality, whether dose escalation is performed. But now standard infections and
It's not clearly audible, Monidipa. Okay, so there has been some disturbance as far as voice is concerned. So this is the way we change the radiation techniques to reduce the toxicities, to prevent the radiation-induced pneumonitis, so that we can deliver adequate dose of chemotherapy. And if we are not able to deliver adequate dose of chemotherapy, then there is some evidence where we can escalate or alter the doses of radiation to get adequate outcomes. Maniputta, can you help me move the slide? It's not moving again.
Hello, Srinivasulu sir. We need your support.
Yes, sir.
Not able to, yeah.
The slide is not moving properly, maybe.
No, no.
Yeah.
Click on that screen and move right arrow, it will go.
Okay, so now you can see this slide?
Yeah, we are able to see it. You
Okay.
can keep it in presentation mode.
But if I keep now, it doesn't move further.
No, just keep it. Now you
Okay.
move right arrow.
Yeah. So now, so if you look into the chemotherapy regimen, if we use, so we have different chemotherapy regimens which we have right from, so the platinum has been the backbone, and we have gemcitabine, we have etoposide, we have vinorelbine, taxane, pemetrexed. All these different chemotherapy regimens are there. So there has been a comparison in head-to-head trials. It has been there. There has been a comparison of etoposide cisplatin versus taxane platinum, where etoposide cisplatin has added an improved survival, especially the progression-free survival has been there, and even few randomized trials have shown an overall survival benefit with etoposide and cisplatin. But the issue with this is it has an increased esophagitis, whereas taxane platinum is associated with more of pneumonitis. Uh, in fact, there are some nuances with the study, but uh, uh, there are more toxicities with etoposide cisplatin. But if you take taxane platinum, it is more of a OPD procedure, single day procedure, whereas etoposide platinum is sort of 5-day procedure which we use. So it has its own nuances. The study is concerned. So any platinum-based backbone, if we use, uh, so we can use any platinum-based backbone. So all of these have shown equally efficacious. So as for in our practice, we use a paclitaxel carboplatin-based regimen rather than a etoposide cisplatin-based regimen. So there has been a randomized trial comparing pemetrexed cisplatin versus taxane platinum or etoposide cisplatin. So the trial was terminated early because pemetrexed cisplatin uh, did not show superiority, but it was less toxic. So all these 4 regimens are equally efficacious and can be applied in practice. Srinivasulu, can you help me move the slide? Hello?
Yeah, tell me what is the issue?
Can you move the slide?
Who is accessing it?
I am accessing.
Yeah, I think you only need to move. Press the right arrow. Select the screen and press right arrow.
Yeah. So if you look into the current approaches of managing, so always a stage 3 lung cancer approach has been in a multidisciplinary approach where we have a pathologist, radiation oncologist, medical oncologist, a surgeon, and a pulmonologist being there. So we not only look into the operability, but also what is the patient's performance status, what is the pulmonary function reserve. So it is not how much I can operate, it is how much lung I can leave back. So there has been enough evidence that a lobectomy is always superior to pneumonectomy. So definitely, wherever possible, we need to have a lobectomy because pneumonectomy causes higher post-operative mortality when compared to lobectomy. So there has been a comparison between sequential chemoradiation versus concurrent chemoradiation. Concurrent chemoradiation, adding chemotherapy to radiotherapy, even in a meta-analysis, has shown an absolute 4 to 5% overall survival benefit, and concurrent chemoradiation radiotherapy has improved survival when compared to sequential radiotherapy. So this is how we approach lymph node. That is what I was speaking about. N0 disease or N1 disease surgery is what we consider. N2 single station neoadjuvant chemotherapy followed by surgery. N2 multi-station or N3 disease we will consider radical chemoradiotherapy. So this is the comparison between radical RT versus sequential RT, and then so adding chemo does benefit. Concurrent chemoradiotherapy in a meta-analysis and even head-to-head comparison has shown overall survival benefit. So these are the multiple chemotherapy regimens we have. So all of them have added survival, but however, the overall survival is around 2 years. That is what we can attain with whatever chemotherapy backbone or chemoradiotherapy is concerned. So this is about the trial which I was speaking, where we use paclitaxel carboplatin. So if you have an elderly patient and where the chances of pneumonitis is higher, so in those occasions you would like to avoid a paclitaxel carbo because it has a higher incidence of pneumonitis. Number one, this particular trial, especially the stripe meta-analysis, has shown that elderly patient with taxane platinum had the highest risk of pneumonitis. So now, in the Pacific era, where we want to use Durvalumab, and even this contributes to pneumonitis in around uh, uh, 3% patients having grade 3 to 5 toxicities. In this set of patients, we would like to be careful as far as prevention of pneumonitis is concerned. So, elderly patients using a non-taxane based regimen and using IMRT would be prudent especially in the era of immunotherapy which we have. So these are the trials where the consolidation has not been helpful, the induction has been not been helpful. So either induction or consolidation chemotherapy with chemoradiotherapy is not helpful. Again, adding targeted drugs like cetuximab also have not shown much benefit. Again, the pooled analysis also has shown that consolidation and induction is not helpful. So concurrent chemoradiotherapy is standard of care for non-resectable locally advanced lung cancers. So this is the rationale of combining immunotherapy post chemoradiotherapy. So it's basically durvalumab is a PD-L1 blocker. So giving chemoradiation will have new antigen expression plus necrosis, and it causes an inflammatory environment, causes influx of immune cells. So all these will result in immune cells trafficking towards the tumor. So it is not just a mere upregulation of PD-L1; it is creating a milieu where there is an effective interaction of the immune cells with the PD-L1 expressed tumor cells. So in this particular microenvironment, if we can have an effective anti-PD-L1 blocker, it has shown a preclinical efficacy and even translating to a clinical efficacy as well. So basically, durvalumab blocks PD-L1 pathway. So with this particular blocking, definitely the immune cells will overcome the tumor cell and resulting in tumor cell necrosis and death. So this is the Pacific study design, which is a phase 3 randomized controlled trial where stage 3 locally advanced unresectable non-small cell lung cancer post platinum-based chemoradiotherapy was given. These patients were qualified if they were 18 years or older with a performance status of 0 or 1, and they should have had a life expectancy of around 12 weeks. And so they were random. It was a placebo-controlled study of durvalumab 10 milligrams per kg for 1 year versus placebo 10 milligram per kg, and the primary endpoints were the progression-free survival and the overall survival. And the overall response rate, duration of response, safety, and patient-related outcomes were also required. So, well, if you look into the Pacific study, the PFS was calculated up to 6 weeks after chemoradiotherapy. So the randomization was up to 42 days from the completion of chemoradiotherapy as well.
I changed the name of Hermione Granger and I can't see.
So this is the Pacific study outcomes of progression-free survival outcomes of durvalumab versus observation versus placebo in the Pacific study design, where you can see a significant PFS benefit of around 17.2 months versus 5.6 months. So this is the forest plot where all the subgroup did benefit. However, the EGFR mutant population did cross unity, but however the numbers were very small and difficult to comment. So whether PDL1 status was more than 25%, less than 25%, it did benefit. However, in an exploratory analysis where the PDL1 was less than 1%, in that subset it did not benefit. So overall, we can see that all subgroup of patients did benefit with Durvalumab consolidation therapy. So this is the overall survival. At 3 years, we have a OS of around 57%. With just a simple chemoradiotherapy, we see a overall survival of around 15%, 20%, and not more than that. So practically, we see only around 10 to 15% of patients surviving with chemoradiotherapy alone. Whereas if we can add immunotherapy, we can in fact double or triple the survival with whatever regimens we have. This is the responses. There has been the response rates are better. The duration of response is better. We can see the objective response around 28.4% versus 16%. And this is the time to distant metastasis death, which is another endpoint, also improved with Durvalumab when compared to placebo. And the toxicity again is a little higher in the Durvalumab arm. Especially, I would like to focus more on what is called pneumonitis. You can see the pneumonitis of any grade is nearly 9.1% versus 3%. So this is one of the limiting toxicities of Durvalumab, and we can see grade 3-4 toxicity is also quite significant. So when a patient who is having chemoradiotherapy, when he develops the symptoms of breathlessness, fever, cough, we have a lot of differential diagnoses, right from radiation pneumonitis to a COVID infection in the present time, and then we have immune pneumonitis due to Durvalumab, with disease progression or COPD exacerbation. So this is all the things which comes in mind when a patient of consolidation Durvalumab presents to us with breathlessness. So then
sir, just sorry to interrupt once, sir.
Yeah.
There's one participant named as Anway 1986. Sir, can you name yourself, sir, so that we can?
Yes, Dr. Anway. He's Dr. Anway Dasgupta.
Okay, Dr. Anway Dasgupta. Okay.
He's a radiation oncology resident.
Okay. Sure, sir. So please carry on, sir.
Chandrakanth, can I ask one question?
Yeah.
Sir, please, can you tell me, you told me in discussions, what is the cutoff for the PDL1 in which clone? That is for the SP263, when you are using the Ventana platform and SP263 clones, that the 25%, we consider the good response only when the tumor cells show the 25% strong homogeneous membrane staining in the tumor cells.
Correct.
And if it is not there, then we look for the tumor infiltrating lymphocytes.
Correct.
If the tumor infiltrating lymphocytes is more than 1%, then among these more than 1% tumor infiltrating lymphocyte, if the positive staining, the same thing, the strong homogeneous membrane staining is more than 25%, it is good. If the tumor infiltrating lymphocyte is very less number, it is just about the 1%, then 100% infiltrating lymphocyte should show the strong membranous staining. Then only we can consider this. If any one of these three above cutoff is there, then we can think that it definitely show the good response.
Correct. So if you look into that's what the different immunological molecules have different platforms. So
yes,
what you are saying of the SP142,
the SP263,
yeah. So so we have trials of atezolizumab. In those trials of atezolizumab, they basically look at the immune cells having positivity for PDL1. Whereas with Durvalumab, we are mainly looking into the tumor cells.
Yes.
So if you look into this particular trial, so irrespective of whether PDL1 is more than 25 or less than 25, it did benefit. But later on in exploratory analysis, they found that those patients who had a PDL1 less than 1% did not benefit. But however, in the present day, we do not recommend to do a PDL1 testing to select immunotherapy as of now, because the data is not that strong that PDL1 will positive will benefit or not benefit. Because if you look into the previous the forest plot, all the subgroups benefited, whether it was PDL1 less than 25% or more than 25%.
Okay.
So this is only an unplanned subset analysis that showed that if the PDL1 was less than 1%, they did not benefit. However, this requires more data and more maturation. So as of now, by blanket, we offer Durvalumab for all locally advanced lung cancer patients who have completed chemoradiotherapy. So we don't do EGFR in this subgroup of patients. We are not doing PDL1 in this particular subgroup of patients.
Okay.
So we have the role only in the advanced metastatic setting. But this is the unplanned exploratory subgroup analysis which I was speaking about.
Okay.
Okay. So this is the exploratory analysis. So we always had a fear that those patients who have pneumonitis do not do well, and Durvalumab is a little difficult to handle drug. But this particular analysis did show that even in the presence of pneumonitis, the efficacy of Durvalumab was maintained, and the majority of pneumonitis was low grade and it was not that severe. So, because in the particular phase 3 randomized trial, we started Durvalumab within 42 days of completing chemoradiotherapy. So, in our practice, we usually do not do response evaluation within 42 days. We do response evaluation above 42 days. So, then we always were little skeptical about looking into the response quite early. So should we really, or if you start Durvalumab post 42 days, does it really benefit? So this less than 42 days was where the patient had to recover from the chemoradiotherapy induced toxicities. So that was the skeptical view, and now we have the data, the real world data. So this particular real world data where we have more than 500 odd patients, 561 patients were included, and the patient population was in par with that of the Pacific trial. The inclusion criteria was also in par with the Pacific trial. The median age was around 62, with both the squamous and adeno being significant number, and then stage 3B, stage 3 patients were included, and EGFR mutant were also included. So if you look into the real world data, even here we have a partial response of around 78.5%, which is quite significant. And we had some 39, nearly 40% patients, more than 42 days also. So even in this subgroup of patients, where we could start Durvalumab beyond 42 days, even in this set of patients, the response was maintained. So now we have evidence that if we do a response evaluation post 6 to 8 weeks or even 3 months, we can start Durvalumab post 42 days, and the efficacy is maintained. So with this, what we can conclude is so we didn't have anything for consolidation post chemoradiotherapy. We had a median survival of around 1.5 to 2 years, and we could cure around 10 to 15% of patients only with chemoradiotherapy. Now, with the Durvalumab having a positive trial in the Pacific study, so we should offer Durvalumab for all patients post completing chemoradiotherapy, and not necessarily we need to start less than 42 days. Even beyond 42 days, the benefit has been shown, and there has been a significant improvement in progression-free survival, nearly more than tripling of PFS, and a significant improvement in overall survival. So now we have nearly 40% patients even surviving beyond 3 years with the recent data as well. So first and the only approved immuno-oncology drug which we have at this point of time, Durvalumab is the only drug which is approved in the consolidation setting post definitive chemoradiotherapy in a locally advanced lung cancer. And we have a tolerable toxicity profile, with pneumonitis being a class effect of it, and majority having low grade pneumonitis. And having pneumonitis does not hamper survival, but we need to look for that 3% population where the pneumonitis is quite significant. So in the present day modality, where we can use novel radiotherapy techniques, and maybe if we can use a non-taxane based agent whenever feasible. So in these set of patients where we can reduce the incidence of pneumonitis, definitely durvalumab handling would be easier. So with this, I would like to conclude, and I would hand over the form to the organizers. Thank you.